have two more. So today we have our presenter, Dr. Sarah Eliza Lockwood, who is an emergency medicine physician and medical toxicologist with a long-standing interest in global health. After completing her toxicology fellowship at NYU in 2006, Dr. Lockwood returned to Washington University in St. Louis and started an ACGME accredited fellowship in medical toxicology. Over the following 10 years, Dr. Lockwood became increasingly involved with global health and humanitarian relief projects. She organized a relief mission to Haiti after the 2010 earthquake, started the scholar track in global health for the Washington University Division of Emergency Medicine, and is one of the global health scholars for the Department of Internal Medicine. Over the years, Dr. Lockwood began to realize that in order to have a sustainable impact in global health, she needed to find creative ways of addressing malnutrition and insect-borne illness, two of the most commonly encountered public health problems in developing countries. With that in mind, Dr. Lockwood started working as the medical affairs lead for Bayer, a global seed and chemical company with innovative technology that has great potential to remediate malnutrition. Dr. Lockwood has lectured nationally and internationally on a diverse range of topics in medical toxicology and global health. She's the one who took us through the series last week, and she's still the one taking us today. And I'm your moderator, Spanjeri, a clinical pharmacist based in KNH, offering pharmaceutical care services and poison and drug information services. You're all welcome. Welcome, Dr. Lockwood.
Thank you. I'm just getting started. Okay, let's see. Let me see if I can share my screen. Here we go. Now, can you all hear me and see my screen?
Yes, we can.
Excellent. Wonderful. All righty. Well, thank you for joining us again this week. I'm Liza Lockwood. I'm the medical affairs lead for the crop science division of Bayer. And I'm really, really delighted to be here helping spread the word about how important crop protection products are and how important it is to learn how to prevent exposures and poisonings and things like that. Today's lecture may be a little bit more technical than the lecture we had last week. We're going to talk about pesticide toxicology and the management of poisoning in general today. And feel free to ask questions after the session. Thank you very much for being here. So once again, we're going to go through this sort of categorically. We're going to talk about exposure and then exposure reductions, poisonings, and then how to protect medical personnel. And then we're going to go through part one of symptoms and treatment for active ingredients in particular, and we'll get into more detail about that. So agriculture has undergone an incredible transformation over the past century. This in 1940 is how much land it took to grow 10 bushels of corn. And over the years, as we made advances in scientific advances in agriculture, we were able to do the same amount, produce the same amount of corn over less and less land. And that is really because we've had some huge scientific advances in modern agriculture that has given us an unprecedented abundance of our food supply. Now, that said, 20% to 40% of crop production is lost to pest, disease, and weed pressure every year. And these scientific advances that we're working on are trying to overcome that pest pressure. So we're going to talk about some of the tools that we use today to do that. Now, Remember that we are exposed to chemicals every day, and there are lots of different routes of exposure. Some of these chemicals may be medicinal, some of them are natural, but we're surrounded by Mother Nature's chemicals every day. And the routes of exposure that people get exposed to are dermal, inhalational, and ingestion. Some of these chemicals pose a higher risk to health than others. The truth is that all of them, including water, can be a hazard. So how do we determine whether or not there's a significant risk to chemical exposure? Well, this is Philippus Areolus Theophrastus Bombastus von Hohenheim, who's also known as Paracelsus. And he was the father of toxicology. And he recognized that the dose makes the poison. Indeed, even water can be toxic in a high enough dose. I've taken care of patients who've had water intoxication because they've drunk so much water that they've had brain swelling. So how do we decide if a chemical is safe? Well, what we do is we conduct extensive hazard and exposure assessments. So when we think of the word hazard, lots of people think hazard is a synonym for risk, but really risk is not quite the same thing as hazard, because you can be in around a high hazard and a low exposure situation, like these little children are looking at sharks in an aquarium. Sharks are a high hazard creature, but they're separated from them. So that's very low exposure, right? You can also have a child petting a baby shark in a little pool, right? And that's a low hazard because the baby shark is not going to hurt him, right? But there's a high exposure there. Now, this diver on the right could be in a pretty precarious situation. So high hazard, high exposure situation is what is going on there. So in order to make sure that there is not extensive hazard and exposure assessments, hazard assessments evaluate the toxicity and the doses required to cause toxicity. So we conduct required studies in toxicology to look at human health impacts of exposure, ecotoxicology, and other non-human, non-target organisms like plants and animals and things like that. We also conduct extensive studies in environmental fate of our chemistries. So whether or not they persist in the soil, leach off, run off, and go into the water. And then how, once they are in the environment, how much of the chemical in what form ends up as residues, and how are they broken down? Then we also look at the efficacy in the product chemistry. So these are a battery of tests that we do, and this can take up being over 100 studies combined, tens of millions of dollars. And this battery of tests, these hazard assessments, take 4 to 5 years just for the data generation piece. They're very strict protocols that we use and study and assess. And then there are guidelines that we have to follow very, very directly to do that. So these are the typical studies that we do. These studies focus on identifying hazards for the toxicologic risk assessment. So we do an acute 6-pack, which we look at lethality, irritation, and sensitization. 28-day and 9-day studies on rats, mice, and dogs, multiple routes of exposure. We do chronic toxicology and carcinogenicity tests. 2 years, the lifespan of a rat, 18-month mouse, and a 1-year dog. We do 2-generation reproduction studies in rats. We look at genotoxicity, acute and subchronic neurotoxicity. We look for endocrine disruption. We try to identify the mode of action if necessary. A lot of times we know what that is. And then we look at the regular toxicology features, the pharmacokinetic features of a chemistry. So adsorption, distribution, metabolism, and excretion. This is a very, very lengthy process that we do. These studies are conducted under good laboratory practice. And good laboratory practice studies are designed by regulatory agencies, which are externally validated, and they have to be reproducible. You always hear in the medical literature about studies that are conducted that suggest a clinical course and that they're not reproducible. Well, if you want to bring something to the market, you have to make sure that your studies are reproducible and that you get the same outcome every single time. So they're auditable, and all adverse effects are reported by law. So I'm going to specifically today focus on the human health exposure assessment. So we did the battery of health effects, the toxicology studies on animals, the hazard assessment. Now we're going to talk about exposure assessment, because this is how we start building a risk model, right? So human health, for human health, the things that we look at are the residues that are left in food and feed, and establish maximum residue limits on crops. We're going to estimate the dietary exposure level from food and drinking water. We're just going to touch on that briefly. And then we're going to talk about exposure during application and how to mitigate that. So how does the exposure occur? How much is the exposure, and for how long? So these are the questions that we answer with this. So let's start right off the bat with dietary exposure. There are many questions about pesticide residues on food. Residue testing and monitoring is conducted by regulatory authorities around the world. Since 1963, the United Nations has published the Codex Alimentarius, a document that provides reference standards for global food safety. And they have a list of maximum residue limits that are for international reference. In the United States, the Environmental Protection Agency sets limits on the pesticides left on food, tiny, tiny traces of pesticides. These are called tolerances. 99% of sampled products have residues below the EPA tolerance. Residues at or slightly above the tolerances do not pose a health risk, and they do not approach the allowable daily intake. And now we're going to talk about the allowable daily intake in just 1 minute. If you have a maximum residue limit, if you have a limit that exceeds the MRL, those products are not allowed on the market. And once again, it's not because of a health risk, because these are tiny, tiny trace amounts. It's actually just because of a regulatory exceedance. So the allowable daily intake is set by this battery of tox studies. So remember that hazard assessment that we talked about, the battery of toxicology studies that we do on these animals. What they do is they establish a no observed adverse effect level, the non-toxic dose in animals, right? And they build in a safety factor of 100 or 1,000. So this is more of a visual of what they do. Every individual crop has its own tolerance. And so soybean, for example, soybean, they do the actual maximum rate application that a farmer can put on the land to give a range of residues levels, right? And remember, farmers are not going to want to spend too much money. So they are not, there's this notion that farmers douse their crops in pesticides. The farmers don't want to douse their crops in pesticides because that really costs a lot of money. And if they exceed the MRL, then they won't be able to sell their products. So they really don't want to do this. So there's a maximum tolerance that's put on the crop. And then what they do, they look at the overall exposure of where else you can get exposed to these chemicals, treated food, air, water, and they come up with a maximum exposure through all routes. The maximum of exposure is orders of magnitude lower than the allowable daily intake. So thousands of times, if not hundreds of thousands of times lower than the allowable daily intake, which remember is the non-toxic dose in animals with 100 to 1,000-fold safety factor. So residues, while they're a regulatory, important regulatory metric, they are not going to pose a human health risk. And remember, we said last time, plants can't run away from you. So they make their own natural pesticides. Mother Nature makes its own natural insecticides. And those chemicals that are found in those plants are actually in much higher concentrations than any residue that you'll find on a plant. So let me give you a visual example of what this means. So if this is the allowable daily intake for soybeans for glyphosate, which is a herbicide, which we'll be talking about later. So a 55-kilogram adult would have to eat 5 kilograms of soybeans every day for the rest of their life to reach the allowable daily intake. That's not physically possible. You die of soybean poisoning before you ever got to the ADI. And this is a popular breakfast cereal in the United States called Fruit Loops. And so you would have to eat a Fruit Loop this big every day for the rest of your life to get to the ADI once. You would never make it through a Fruit Loop that size. So that gives you a perspective of how trace these chemicals are. So let's talk about now, how do we reduce applicator exposure? So applicators, farmers who are putting these chemistries on their crops, how do we reduce their exposure? And this is really important. Once again, how can we determine whether the use of a product is safe? Well, we do our risk assessment, right? And that involves a hazard assessment, which is the battery of tests, and then measuring exposure. So risk mitigation is like having personal, for this group, is having personal protective equipment available. So as you can see on the left, you've got people sunbathing, and the sun can be risky because if you overcook yourself, you can get a bad sunburn. Well, personal protective equipment is like having a shade and sunblock to mitigate that risk. So the risk and not hazard determines whether or not a person is safe in a situation. So specifically for operators, for farmers and applicators, what we're going to do is look for a risk assessment for plant protection products here. So there's the acceptable dose, right? Dose makes the poison. Acceptable dose of it that the applicator is exposed to. And that's going to be dependent on the inherent toxicologic properties of the molecule. Then we're going to look at operator exposure, and that's going to be dependent on the formulation, the mixture. So we've got the active ingredient and all of the other ingredients, and we can talk about that a little bit, and the specific use pattern that the operator is going to be applying these chemistries to their crop. That includes the application rate, the equipment, the actual crop. If you've got a crop that's low down on the ground, you may be spraying and the spray goes downwards. But if you've got a canopy crop or a crop that's a little bit higher, you need to mitigate that risk so the chemistry doesn't go into your face and things like that. The plant protection product use is deemed safe if the exposure is less than the acceptable dose of the chemistry. So let's talk about the safe use, right? So this is the Safe Use Ambassador Program, and we are wanting to convey how important it is to use crop protection products safely, just like pharmaceutical companies want to use their products safely. So there's a really important set of people that are working on these different aspects. So who is responsible for safety? So industry needs to ensure that plant protection products are safe for operators by generating data and risk assessments that prove safety. Same thing for dietary evaluations and things like that. Regulators control industry and farmers to provide guidance. So they will monitor these crops, and they will have guidance in terms of laboratory testing that needs to be done, field testing that needs to be done, and the way those tests need to be conducted. And farmers will be using the product according to label instructions. And if farmers use a product according to label instructions, we know that they can apply these products safely and protect the food supply. As we talked about in the previous lecture, weeds harbor fungi that are transmitted by insects to crops. And when those crops are infected by different fungi, they can produce mycotoxins. So you can see this moldy corn here. And one of the ones that we get very concerned about is aflatoxin. So if we want to prevent that chain of events and we want to prevent resistance of different organisms, we need to use a multitude of different tools to protect human health and the food supply from mycotoxin infections. So global versus regional regulations. So we're talking about now just sort of the overarching way things are regulated. Globally, about 25% of countries use a risk-based approach. And other countries will adopt those kinds of regulations to ensure safety of food. Now, regional or local regulations can define a safe use based on risk assessments if operator safety is part of the regulation. So they want to assess whether or not the operators are what their exposure is like and how they can be protected. There needs to be an assessment with a scientific risk-based approach that's consistently applied everywhere. And the registration process is transparent and understandable. So if that can be a very expensive process. So what can we do to help globally achieve these standards? So the Food and Agricultural Organization has a code of conduct that gives us guidance on how to do this. The Food and Agriculture Organization Code of Conduct on pesticides, together with the pesticide registration toolkits, provide an excellent blueprint to assess operator safety. In particular, the pesticide industry should ensure that each pesticide and pesticide product is adequately and effectively tested by recognized procedures and test methods as to fully evaluate its inherent physical, chemical, or biologic properties. It also should be testing its efficacy, behavior, and fate, and then once again, hazard and risk with regard to various anticipated uses and conditions in regions or countries. So one of the things that we hear quite often is that no country should be using a chemistry that is not approved for use in Europe or the US. The difficulty with that issue is that Europe and the US have one of the best pesticides ever, and that's called winter. And so when you are located on the equator and you have pest pressure 365 days a year, 7 days a week, and 24/7, that you require maybe a different set of tools than you would necessarily up in the north, because you do not want to breed resistance. And so if you need to have access to different tools that you wouldn't necessarily need in the northern or far southern hemispheres. So anticipated use is very important here because we need to tailor that to make sure that we're not building chemistry resistant insects or weeds or fungi. So we need to ensure that the proposed use label claims and direction packages and the safety data sheets and technical literature truly reflect the outcome of these scientific tests and assessments. And we also need to provide advice and assistance in the training of technical staff involved in the relevant analytical work. So this is the FAO recipe. It's like baking a cake. This is what you need to protect your crops. You need, for a cake, you need sugar, eggs, butter, cream, stir, bacon, and joy. But how do we actually make that into a technical recipe for what farmers are going to ultimately use? How many eggs? How much milk? How long is the baking time? Well, we have internal standards for risk assessment that ensure a globally consistent baseline for product safety. So our safety standard and the Food and Agricultural Organization's Code of Conduct are complementary. So our vehicle is to transparently deliver on this requirement to industry. So we produce safety data, we produce data on our risk assessment, and then produce data on our risk management. We established the full methodology to perform the necessary evaluations that can be considered complementary. So what's new in this? This actually considers scenarios that are common in low and middle income countries that we may not be facing in the north. So we can tailor our recipe for operator safety by doing this testing. Okay, so the operator safety standard is the technical guideline for our internal assessment, specifically for users in low and middle income countries. So we collect the data, the hazard data and human relevant systemic thresholds. We look at dermal and inhalational absorption. And then we look at the exposure and risk assessment. So different countries and crop specific factors using a real scenario. What kind of equipment operator exposure level is a systemic endpoint, normally based on a subchronic toxicity study conducted in dogs, rats, or mice. This is a 90-day dog study, and they will have 3 concentrations that are fed daily. So they'll do a high dose, 1,000 milligrams per kilogram, and look at the endpoint of death to make sure that there's a dose there. And then 100 milligrams per kilogram of body weight per day. And a parameter that we look at is reduced body weight, 10 milligrams per kilogram per body weight per day. And this is how we establish the no adverse effect level. And then 1 milligram per kilogram body weight per day. This is how we build in a safety factor of 10. So because dogs are different than people, so we want to make sure that people are getting a minimum exposure. And then 0.1 milligrams per kilogram body weight per day. And we eventually get to the acceptable operator exposure level. So you can see they're orders of magnitude lower, and 0.05 milligrams per kilogram body weight per day is the corrected version for oral absorption. What are the principles of operator exposure modeling? So we've done the hazard assessment. We've come up with the dose, right? So now we're going to look at the exposure. So we've looked at the hazard. We're going to look at the exposure so we can have a legit risk assessment. So we will dress applicators in a suit with a monitor on the side that can do readings. All right, and then we will have them go do their daily assessment, mixing and loading, checking under the truck to see if there's if the nozzles are working correctly, and then we'll have them spray as they would normally. The quality criteria is that this has got to be GLP laboratory compliant. So you have good laboratory practice needs to be followed here. It's got to be well documented. It's got to be representative of what the real life scenarios for applying these. And you have to do a sufficient number of tests over and over to make sure that you're documenting these exposures accurately. Professional operators are monitored during this. And then we do multiple studies with multiple replicates to make sure we're getting accurate data. We will measure the leftover residues on the person's PPE and see what's there. And then what we'll do is we'll do a statistical analysis to find correlations and model development for minimizing exposure. And it depends on the active substance, if it's a liquid or a granule or a dust, and a whole variety of things we'll measure. We'll look at the dermal absorption of the concentrate, dermal absorption of the dilute, because remember, you mix a lot of these pesticides in tanks, and so they're very, very diluted. And so we're going to identify the main factors enabling the normalization for generic use: work rate, duration, equipment, work task. And so a whole variety of tests are done to model accurate exposure. And then what we'll do is we will make the label for our product X, whatever the product is, and have different scenarios under which the product can be used safely. Why is this meaningful? Well, because there are multiple ways of applying pesticides. So we need to have data from all of these different ways. As you can see, somebody who has got a pesticide being applied on a tractor, they are removed from that exposure and it's moving away from them. That's very different than somebody applying a pesticide on a rice paddy in this situation. So we want to take the multiple ways of a pesticide being exposed, or a person being exposed to a pesticide, and minimize that exposure. Plant protection products are important for food security, right? But pesticides are chemicals and they should be treated as such. We need to make sure that the safety of operators is ensured. But remember, the dose makes the poison. So what did we do to try to get companies to help us do this? So the big 6 companies at CropLife International agreed to develop an industry-aligned safety standard. So we've got Bayer and Syngenta and Corteva and BASF and FMC and Sumitomo Chemical in 2023 got together and agreed by a leading committee within CLI to commit publicly to an aligned operator protection goal, right? We want to make sure that the farmers that are putting their chemistries on their crops, that they are actually protected. So we as industry have committed to doing that. And global regulators have also gotten together to try to help with this. And this is a big organization that is trying to do the personal protective equipment and personal protective strategy that global regulators, including the FAO and industry and academia, have gotten all together to try to minimize farmer exposure. So once again, back to the magic triangle of safe use. Industry needs to ensure that plant protection products are safe for operators by generating risk and data assessment that improve safety. Regulators control industry and farmers and provide guidance, and farmers use the label according to, or the product according to label instructions. So now let's look at toxicology. Okay, so now we're getting into a little bit more detail. So how do we get routes of exposure for crop protection products? Again, this is very much the same as the routes of exposure that we get with everyday chemicals. So you can have dermal uptake. So that uptake is depending on the substance. For newer or active ingredients, it's in most cases, it's low toxicity by this route. So we have developed, as we've evolved in our development of chemistries, we want lower and lower toxicity chemicals available to people and for people. And so dermal exposure is not a big route of exposure for most people. Poisoning is possible with organophosphates, and we're going to talk about organophosphates in more detail next week, even in medical personnel. So it's really important to look at how you've got to protect medical personnel, and we'll get into that a little bit more, from organophosphates. And then uptake can be influenced by solvents dermally. So remember, if you use soap and water, or if you have an oil-based solvent, it can cause a difference in whether or not you have dermal absorption. In inhalation, if you've got aerosols or dust, sometimes you can get inhalation exposure. Dermal absorption and inhalation can really be easily reduced and avoided by the use of correct clothing and PPE, as well as technical equipment. And then ingestion, most of the time, you are not going to see that route of exposure. Very few exceptions, except for suicidal attempts, criminal poisonings, or accidental ingestions. And we'll talk about how to prevent that. So how do you avoid these kinds of exposures, right? You avoid these kinds of exposures. So you can see here up at the top left corner, Germany in the 1950s, people were just spraying willy-nilly, and we want to avoid this scenario. DDT was what they're spraying in this particular picture, and that had very low kind of toxicity generally for people, but it had a lot of environmental impacts. So we can talk about that more, but we generally want to avoid this particular scenario. So depending on what you're spraying, as you can see the PPE examples in Vietnam, if you're spraying overhead, you don't want the chemistry to settle on your face. So you need different kinds of equipment to prevent those kinds of scenarios. So for your health and that of your family, you need to wear the correct protective gear. And there are lots and lots of posters and available for those kinds of things. I personally have taken care of a lot of patients that have decanted chemistries into a soda bottle and put that in the fridge, and they have gotten very, very sick from that. There are cases of paraquat poisoning, people who inadvertently drunk some paraquat that way. There are cases of, we had a hydrofluoric acid case that was really, really terrible. So never decant a chemical that's in its original bottle into a bottle that people can drink. And then never fill water or food into, a lot of people like to keep, extra plastic bottles, but this is really important. You do not want to have an accidental ingestion because you've used a bottle. Well, now what do we do when we have for clearing the life cycle of the chemistry, right? So you want to triple rinse your pesticide containers and then dispose of them for recycling. And we have lots of programs geared to trying to get people to do that so they're not inadvertently exposed. Okay, so there are other things we can do also. So not just PPE, but we can also use stewardship to reduce the amount of spray drift. So you can see this helicopter's applying a spray and the spray is drifting. You can really mitigate that by 90% with the different kinds of nozzles that you use. So we have teams that actually design nozzles that can really decrease the amount of drift and the amount of exposure that's in the environment and for people. As you can see, there are two different kinds of nozzles on this particular sprayer. On the right, you can see that there's a lot more drift there. On the left, you can see it's much more directed. So different nozzles at a spray boom make a huge difference in exposure. Now, seed treatments. This is a really interesting thing. So Mother Nature coats seeds with natural pesticides to protect them from pests. Remember, survival of the fittest is the driver of evolution. So, for example, apple seeds are coated with skin that contains amygdalin. Amygdalin gets converted to cyanide when ingested. And so remember our discussion about residues? You would have to eat over 100 apple seeds for this to be a problem. And so this is a classic example of the dose makes the poison. We would never tell people to stop eating apples because there are trace residues in there. Remember, an apple a day keeps the doctor away. So we figured out how to take a leaf out of Mother Nature's book and coat seeds for planting. This has multiple advantages. You can limit the amount of aerial spraying. You can decrease the amount of exposure to farmers. And you can, there are very few off-target species exposures. So this minimizes the dose that it needs to protect a crop. So initially when the seed is coated, you have a contact effect against soil pests. And then you can control those soil pests as the seed grows. And then trace amounts of that chemistry can get into the leaves to control the pests that directly feed on those plants. And so this is a way of really dealing with destructive crop pests like fall armyworm and a variety of different things like that. If you use this method, you can actually do a lot more with less. So if you're treating the whole area, the soil is getting all covered. You can do granular treatment, and that those are furrows that you put little kind of almost pebbles, granules of pesticide in, and that's less treatment that you need. And then seed treatment is really you need much less active ingredients and much less treated area. So it's a really neat way of minimizing the dose that's needed. So if you, once again, this is sort of a visual of the amount of land that you need. 10,000 square meters when you're spraying, so you're spraying everything. Or you can do furrows, which reduces the amount of land that's exposed. Or you can do seed treatment, so which is really reduces the amount of chemistries that you need. Going forward, this is a really exciting development, and we did some work in Kenya with this because during the locust plague in Kenya a couple of years ago, there were only 5 crop dusters available to spray. Fortunately, we're beginning to be able to use drones to address that problem, and they have many advantages. They have much less water volume is needed than it is for a spray pack. It's much cheaper. It's 50% of the treatment cost versus manual application. Much lower PPE requirements versus manual application. So you don't necessarily need somebody with a spray pack and then in hot weather covered with PPE. It's got comparable or even better control versus manually spraying. It's 30 times faster, and it really saves labor and in agriculture, labor is a big deal. There's not enough people to do that. So now so those are some of the protection measures we take to prevent exposure in farmers. So let's turn to the issue of poisoning. and how to recognize and manage overdoses. This section is going to be really divided into two parts. We'll do the first part this week, and we'll follow up with a second part next week. So let's look at the magnitude of the problem. So now remember, we were talking about what the way we think of exposures in farmers is really kind of dermal or inhalational, and we use PPE to prevent that from happening. And the variety of PPE is different. Now we're turning to actual suicidal or accidental exposures, and these are largely ingestions. So including suicides, there are about 3 million poisonings per year with over 250,000 fatalities per year. The World Health Organization estimates in 2004 that this was related to 1/3 of the causes of suicide globally. Now, what's interesting about that is we, through the Safe Use Ambassador Program and Crop Life, we are starting to develop a program for reporting pesticide exposures through this route, so we can get a better handle on how many poisonings there actually are. There's not a lot of reliable data on that, so we're trying to start developing that across sub-Saharan Africa. Occupational poisonings most often occur via the dermal route, by contact of unprotected skin in the face, hand, forearms, neck, and chest. Inhalational poisoning is possible during spraying in greenhouses or unprotected tractor cabs, but most of the time, these kinds of things are ingestions. The signs and symptoms of exposure are something that you should take into account, and we're going to next week in particular talk about something called toxidromes. So toxidromes are a constellation of signs and symptoms that you can look at from the end of the bed and determine what you think the agent is that the person took. So we're going to talk about toxidromes next week, but I'm going to talk about a few things that sort of general principles that can help you manage patients with these issues. So symptoms may be caused by the formulation ingredients, active ingredients, or both. So what a formulation is, as we talked about last week, is you've got a small percentage of the formulation is going to be the active ingredient, the pesticidal ingredient. And then it's going to be mixed with a surfactant, which is like a detergent or a solvent. And then it's going to be, there may be some defoaming agent and preservative in there. If you ingest a surfactant, that can cause caustic injury, and that can be the thing that a surfactant's like a detergent, like laundry detergent. So if you drink laundry detergent, you can get a caustic injury to your esophagus and GI tract. If you inhale it, you can get pulmonary injury as well. So the symptoms and signs may be due to the surfactant, but it also may be due to the active ingredient. And it depends on the relative toxicity of the active ingredient. As we've developed over time, less and less toxic things, the active ingredients playing less of a role in these kinds of ingestions. So a combination of active ingredients may influence effects and toxicities. So carbamates, which we're going to talk about next week, might inhibit the metabolism of pyrethroids, which we're going to talk a little bit more today. Only a few active ingredients cause typical signs and symptom combinations. So toxidromes, for example, organophosphates and carbamates will cause a cholinergic toxidrome. We're going to talk about that next week. Thiram and other dithiocarbamates will cause alcohol intolerance. So you can get a disulfiram effect. And pyrethroids can cause a cold burn of the skin, which we're going to talk about today. Most pesticide-related illnesses have signs and symptoms that are common or similar to common medical conditions. So the moral of this story is that treat the signs and symptoms that you see. Most of these ingestions you need to treat symptomatically. There's not a specific you can alert. You can get a detailed environmental and occupational about the patient's work, home environment, can indicate whether or not there's a particular pesticide poisoning. The Environmental Protection Agency has a whole manual. So typically, diagnosis, right? So the diagnosis, what time and a type of exposure, what pesticide. If the patient is obtunded, it's very hard to get that information. The route of exposure, oral, sometimes you can see caustic injury in the mouth, right? If you can't get a great history. Skin contact, you can see if they've got it on their clothes. What's the amount ingested? Did they just get a drop or a shot or a mouthful? And then what kind of method and timing of application was done on which crop? If you want to get a hold of the packaging, that can be very helpful, unless, of course, it's been decanted into a different package. So hopefully it's not. Hopefully you can get the original packing. The family or colleagues can go get it. Vomit before arrival. What are the things that you need to do? Was there decontamination done in the field? Were they given any emetics, absorbent, or home remedies? Water, milk, lemon juice, those kinds of things. Lots of people try to neutralize things, and they probably really don't need to do that at home. And then as the patient evolves, you look for new signs and symptoms: headache, dizziness, nausea, blurred vision, a whole variety of things. And then you want to assess how they were exposed. Was it because of leaking equipment? Were they mixing and loading this pesticide? Were they spraying it and did it splash up in them? Or did they have an empty or broken bottle found near the patient, or an unclear liquid? This should give you, these are the kind of details that you can look for when you've got the suspicion of a pesticide poisoning. You may want to take samples of urine, blood, or vomit, and you may use, a variety of ways of doing this test, but the testing is really not reliable in these cases. Often you can't get the test for these, and if you do, they're too late. This is just a sort of visual that you can have, and put in your around your operators who can do this for first aid. If you suspect there's a pesticide poisoning, put somebody in the recovery position, keep them in the recovery position that's over on their side until the ambulance can take them to the hospital, and then you can give your history to the provider. So these can be used in settings where people may be exposed to pesticides. And then this is a poster that you can use in the hospital. So your typical ABCs: secure the airway, make sure that they're breathing okay, check the circulation, ABCs. If you need to do CPR, go ahead and do CPR. You want to be very careful with oral ingestions of doing mouth to mouth. As a matter of fact, we're moving more away from mouth-to-mouth resuscitation because of potential exposure. So if somebody has an organophosphate overdose and you do mouth-to-mouth resuscitation, they can off-gas and you can get sick. So we'll talk about that in more detail. The most important thing in these cases is really treating the symptoms. So it's symptomatic care. They may just need some decontamination if they're awake and alert, but if they're obtunded, you want to do aggressive symptomatic supportive care. One of the common things that you see in pesticide overdoses are seizures. And basically, you can treat these seizures with a variety of different benzodiazepines or phenobarbital. They're not recommended for prophylaxis. Okay, this is really only in case of seizures. And here's the dosing for this. You can have this particular slide deck, so you can have the dosing of these kind of things. If you are not able to stop them from seizing, you really want to try to get them to a tertiary hospital so they can get propofol. Okay, these are the don'ts. If you've got somebody who's ingested a pesticide and you are not sure of what it is, do not neglect decontamination. Decontaminate. So if they've spilled it on themselves, try to wash it off. Wash the skin and the eyes. Undress them from drenched clothing so they're not having continuous external exposure. Do not give milk in oral poisoning. Actually, if somebody's obtunded, do not give anything by mouth anyway, because it can make things worse. So oral poisoning, it will increase the absorption of fat soluble toxic substances. If they're awake, you can give them a glass of water, but really we try to steer away from that. Lots of people want to kind of do water or gastric GI lavage and stuff like that. I'd probably not do that these days. Often when people are vomiting, they're decontaminating themselves. So and then lots of people want to neutralize things in the stomach. So I would not try to give the opposite of, if they ingested an alkali, give an acid. We don't need to do that kind of stuff. Generally speaking, vomiting, especially if somebody's got a solvent or a corrosive, you don't want that coming back up and corroding the esophagus more. So you want to leave that kind of alone. And then don't try to keep the patient at home and only take the patient to the hospital when things are critical. You really want to get the patient to the hospital soon. Now, when you've got medical personnel they need to be protected as well. As we talked about earlier with mouth-to-mouth resuscitation, patients can be off-gassing. And this actually becomes a really big deal. So for example, one of the doctors who trained me in medical toxicology had a patient, a 19-year-old young man, farm worker, who drank malathion. And when he drank when they got to the farm, he was obtunded, and they wound up decontaminating him on the scene, took off his clothes and cleaned him up, and then put him on a helicopter and to transport him to a higher level of care. In the helicopter, the pilot started having a little bit of blurry vision, and the team taking care of him started getting nauseous and feeling queasy and things like that. Organophosphates can off-gas, and if they off-gas into an enclosed environment, and you've got a pilot who's got pinpoint pupils because he has been exposed, you can crash, and the whole medical team can be affected. So you really want to make sure that it's important that medical personnel are protected as well. So toxic substances are toxic for everyone. So this clearly includes medical personnel. No nurse, no doctor, no helper is immune against these things. So you want to protect them as well. So risk from the side of the patient is the substances on the skin, excretion through skin or exhaled air, and vomit can off-gas as well. So the routes of exposure are the same, right? Dermal exposure, you can get organophosphates causing dermal absorption. Inhalation, phosphine gas. We're going to talk about phosphine gas next week. You can get splashes of irritating or corrosive substances in the eyes. And then you can also, if you get organophosphate in your eye, you can get blurry pupils too. Okay, so what can medical professionals do? We've got our own PPE, right? MDs need PPE too. So we can wear goggles or safety glasses, nitrile gloves, latex. Now with organophosphates, it can cross latex gloves. So you want to be careful with that. And then you want to wear a long sleeve shirt to make sure the skin of your arm is covered. And if the patient is very contaminated, if they're covered with pesticide, you may want to protect yourself with a protection suit. Okay, so that's PPE, limiting doctor exposure, limiting absorption and things like that. Let's talk about active ingredients themselves. And this is part one. We're going to get into chemistries, other chemistries next week, which actually, in my opinion, much more interesting chemistries next week. But we're going to talk about acute intoxications and their treatment. Okay, this is not chronic exposures and their potential effects. This is how to manage patients in the hospital and kind of what the mode of action is of these chemistries, so you understand how they work and how that leads to symptomatic presentations. We are going to cover the active ingredients that are used in Bayer products registered in Kenya, and then those that have become generic, like organophosphates or carbamates. So pyrethroids. So back to our daisy. They've been registered since the 1970s. And remember, we talked about our daisy last week. They make a natural insecticide that's called pyrethrum, which is made up of several different pyrethrins. And remember, plants can't run away from you, so they use Mother Nature to protect themselves from insects. And all the way back at 400 BC, the Persians discovered that these daisies had insecticidal properties. And so they sold Persian powder along the Silk Route in order to protect armies from lice and fleas and other things like that. They didn't realize hundreds of years ago or thousands of years ago that these had insecticidal properties and insects carried diseases for people. But since then, since the dawn of the 20th century, they figured this out, and they were able to use this to protect people from diseases like malaria. Bed nets are soaked in pyrethroids to prevent mosquito bites, and these are really a cornerstone for public health and prevention of insect-borne illness in people. And then they're also used in crops. So these are alternative to organophosphates and carbamates. They're less toxic to vertebrates. They make up close to 20% of the global market for insecticides. We use them in agriculture and crops and stored grains. We use them in home and garden situations. So once again, for mosquito nets, preventing roaches, bed bugs, preventing aphids from in gardens. And we also use them in livestock and dogs. Livestock can get insect-borne illness, and their pyrethroids are very important for treating illness or prevention of illness, insect-borne illness in livestock and dogs. You want to avoid this chemistry in cats. So these are toxic to cats, but these are really, really important. So there are two types of pyrethroids, the alpha cyano and the non-alpha cyano pyrethroids. Both of these will cause a cold burn called a paresthesia, or irritation is the first symptom. And if you spill some on your hand, it'll feel like a cold sunburn, like a tingly. From a clinical point of view, the different central nervous system effects are negligible. You can get a little bit sicker from the alpha cyano version. So these are the structures. You don't need to memorize the structures or anything like that. But if you have a significant exposure for the non-alpha cyano pyrethroid, you may see some fine tremor in the patient and hyperreflexia in the patient. One of the tip-offs that you have in alpha cyano version is that they can have lots of salivation, kind of excitability, hyperreflexia, that kind of thing. And they may have a chorioathetosis. It's not really critical, though, to differentiate between these two exposures. So how do pyrethroids work? We touched on this a little bit last week. The mode of action is that they have a transient effect on voltage-gated sodium channels. So remember, sodium channels are really important for the saltatory conduction of signals down nerves. And so this interferes with transmission of the action potential in the central nervous system and down the peripheral nerves. And so what it does is it causes a depolarization, so repeated firing of those nerves until those nerves really, really get tingly. So it just disrupts the propagation of an action potential along the nerve membrane. If you have an exposure with vertebrates, so mammals and people and things like that, you get a very rapid clearance with no cumulative or residual effect. So you may have people who've had a high dose ingestion of these may have a tremor, uncoordinated movement, and a high enough ingestion, they can get seizures. Okay, so these will be high dose peak tissue levels in the central nervous system. The effects resolve within minutes to hours after exposure because these are metabolized and clear very quickly. Now that's the active ingredient. If you have a formulation with a solvent or a detergent, a surfactant, can actually have corrosive effects on the esophagus, so you can get sick from that. This is the active ingredient. So how do you manage this? Once again, symptomatic supportive care. So with pyrethroids, low concentration in products have a very high margin of safety. You don't need much active ingredient to control pests. And the effects, once again, that you see, the clinical effects are consistent with the mechanism of action. They've got a tremor, they can have motor coordination, and then convulsions if they're really sick. And once again, we talked about using benzodiazepines and phenobarb in an escalating dose in order to treat this. If you're going to use phenobarb, you most likely will have to intubate the patient. And then once again, you want to consider the formulation, the solvents, and make sure they're not aspirating those things, and you want to protect their airways if there's a solvent involved. The most common thing that you see with these particular exposures are paresthesias, so localized burning, itching, tingling sensation in the area of contact due to stimulation of the sensory nerves. It resolves over time, over 24 hours as it's absorbed through the skin. And you don't need to really treat that. You can assure the patients with tingling can resolve. And this is the cold burn discussion. It stimulates free nerve endings in the skin and mucous membranes and triggers the nociceptive fibers in the dermis and cold receptors in the dermis. These are also present in the upper airways, but not in the lungs, so you can get some tingling. So itching, burning feeling of the skin, a rash is possible. It's concentration dependent, not dose dependent. There's no increase with time or increasing dose. This is not a systemic toxic effect. It's a local effect. It's not a poisoning. And most often people, when they see it, when they talk about it in the face, around the eyes, like they've tried to wipe away sweat with a contaminated hand, they may get some funny tingly feeling. But this is, once again, not poisoning. Some people don't get it. Other people can get it very, just by being exposed. And this may be a polymorphism of their carboxyl esterases in their skin. If it's warm, like a warm shower, that may make it worse. You can give them a little bit of vitamin E cream or corn oil. So these are the pyrethroids that are registered in Kenya. And once again, these are the symptoms that you can have. Locally, you can get paresthesias and irritation with mucous membrane or skin involvement. If somebody drinks it and they inhale it, you can wind up with pulmonary edema, asthmatic kind of airway hyperreactivity kind of thing. And then people who are sick will have tachycardia, hypotension, palpitations. They may have nausea, vomiting, diarrhea, dizziness, and once again, seizures and chorioathetosis. Once again, systemic toxicity via inhalation and dermal route is very low. And you want to decontaminate these people. You want to wash or shower the skin with water and soap, irrigate the eyes thoroughly. Generally not recommended to do gastric lavage. We're starting to really move away from GI decontamination because it doesn't tend to, especially if you've got an obtunded patient, you can really increase the risk of aspiration or increase the esophageal mucosa being exposed to corrosives or solvents. We are not doing activated charcoal in these cases either. Some people want to do cathartics. That's just going to make kind of a mess. If you've already got, especially if you've already got somebody vomiting, you don't want to give them diarrhea at the back end and have to deal with that. So generally speaking, we're stay away from cathartics. Activated charcoal is not really used in these cases. There is no antidote to this, and we treat these with benzodiazepines if they're seizing. So moving on to a different class of chemistries. So this is the flowering nicotine plant. And back in the day when people used to use nicotine as an insecticide, and it's a natural insecticide, and we've smoked this insecticide in the form of cigarettes and cigars and tobacco and things like that. So lots of people have had exposure to this particular plant, and it's had a very, very interesting history on its own. But nicotine is very highly toxic for mammals, and so we've used this Mother Nature's insecticide and tweaked it so it won't be so toxic for mammals. And we've done some really interesting science to make a different class of chemicals called neonicotinoid insecticides. And so this is new, nicotine-like, oid is like. These are insecticides designed to mimic the effect of nicotine on the nervous system of insects with far less activity in humans or other vertebrates. Imidacloprid was the first neonic. It's a fascinating chemistry. It's most well known, and lots of people are very interested in this class of chemistries. And we can talk about that in a little bit more detail. So natural, organic, nicotine is a natural organic chemical, and it mimics the effects of acetylcholine at nicotinic receptors in vertebrates and insects. So let's really quickly just review acetylcholine. Acetylcholine is a neurotransmitter that is involved with muscle movement, and it's involved with signaling down nerves in the central and peripheral nervous system. So if you remember, your parasympathetic nervous system is the nervous system, part of the autonomic nervous system that makes you rest and relax, and that's critical for survival. You need to be able to digest your food. You need to be able to eliminate your food. You need to be able to have bladder contraction to urinate, those kinds of things. So rest and digest, your parasympathetic nervous system. When you release acetylcholine from the presynaptic nerves onto the postsynaptic nerve terminals, you then send another signal down your postsynaptic nerves onto the tissue of interest. Release of acetylcholine there causes muscle contraction. So if it causes salivation, it can cause muscle contraction in your lacrimal ducts. So you have lacrimation. You wind up having esophageal and GI contractions, right? So that makes you have peristalsis, and defecation and urination. So the contracture of those muscles through the parasympathetic stimulation of muscarinic receptors. For nicotinic receptors, you have those at the neuromuscular junction. And so when you release acetylcholine at the neuromuscular junction and you bind to a nicotinic receptor, that's going to open a sodium channel and cause a cascade of events in the muscle cell and make that muscle contract. So your voluntary, your somatic nervous system, where you can move your arms and legs, are how that happens. So releasing acetylcholine at the neuromuscular junction makes you contract. If you have excess acetylcholine at the neuromuscular junction, you will have a depolarizing blockade. You will stimulate that muscle until it fails. And when it fails, you get paralysis. So nicotine is an organic chemical that can do that, right? Invertebrates and insects. It's not selective. Synthetic neonicotinoids are synthetic insecticides designed to stimulate selectively nicotinic acetylcholine receptors in insects and not in people, so much lower toxicity for people. This is a really important chemistry for the global pest control market in 2020. It's very, very, a lot less effective on the subtypes in the peripheral nervous system of vertebrates. It won't cause paralysis. Very poor penetration of the blood-brain barrier, so it won't cross the blood-brain barrier. Nicotine, part of the reason why nicotine itself is so addictive is because it crosses the blood-brain barrier. Nicotine overdoses cause nausea, vomiting, salivation, sweating, hypertension, tachycardia, ataxia, tremor, dizziness, and seizures. That is a cholinergic toxidrome. We're going to go into that in detail next time. Neonics does not do this. So it's much less toxic for mammals than it is for insects. Nicotine is 5 times more toxic to mammals than rats, houseflies than rats. Imidacloprid is 10 times less toxic to mammals. Clothianidin, 100 times less toxic to mammals. So really, really has a very large margin of exposure. So you can use very low application rates and very low toxicity to humans. And interestingly enough, these can be used as seed treatments rather than sprays. There is some thought that this could be really good in the management or in the prevention of malaria as well. So here's what you see visually. So for vertebrates and humans, a natural acetylcholine stimulant will bind to the receptor and cause a strong response. Nicotine has a very good binding affinity for the nicotinic receptor with a good response. For mammals, neonics, you can see here, really don't bind to the receptor well, so you don't have, or very limited response. Neonics fit the insects' neonicotinoid receptors much better than humans. And once again, neonics don't cross the blood-brain barrier for people, and nicotine does. So in exposures, for mammals, there are clinical signs that they've seen in toxicology studies where they've given high doses. You'll get some tremored and impaired visions, or no effects at high dose with suicide attempts. They're actual suicide attempts where you haven't had any kind of effect. Effects tend to resolve within hours after exposure because they get metabolized. This is not a cumulative buildup. Serious illness is rare, and it only occurs after large nausea, vomiting, headaches, dizziness, and abdominal pain. And the management of this is symptomatic. You know, if you have somebody who's smoking, a nicotinic agonist maybe could exacerbate symptoms, but most likely the formulation, the surfactants or things like that in the product may cause more injury than the actual active ingredient. Cases of acute poisoning are really, really quite rare, despite wide usage. 92% of these cases report mild to moderate symptoms, some nausea, vomiting, headache, dizziness. Management of acute cases is symptomatic. There's no antidote for these, and most people have complete recovery. Most symptoms and complaints are, once again, due to the formulation, and most formulations contain 20% less or less of insecticides or low exposures. Here are some references to go to if you're interested in reading more about pyrethroids and neonicotinoids. Really, really interesting things. So as we wind up, these are our commitments. We're ensuring that appropriate programs are implemented to train and instruct Bayer employees and customers regarding the responsible management of Bayer products and services through their life cycle. We're doing safe use farming trainers, over 1 million farmers a year, to ensure that our products are handled with the greatest possible care and that farmers worldwide receive proper information about the safe and responsible use of crop protection products. We're providing information material about dress codes and trying to figure out how to best get the best PPE to people. And also trying to promote professional crop protection applications to increase the number of trained and professionalized operators, and at the same time reduce the number of untrained farmers using crop protection products. Product stewardship, we are committed to the responsible management of our products through our whole life cycle. Product stewardship is the responsible and ethical management of a product throughout its life cycle, from the invention through the ultimate use and finally discontinuation. We are very crop protection stewardship itself focuses on the use phase of our products with our stewardship commitments. And we have this for all of our seeds and traits, biologics, crop protection products, and services. Since 2016, Bayer has committed to only sell crop protection products that have active ingredients that have registration in at least one OECD country. In 2012, we stopped selling any World Health Organization Class 1A, 1B crop protection products, regardless of their regulatory approval status. We ensure compliance with these commitments by establishing and regularly reviewing internal processes. And additionally, these commitments cover crop protection for agricultural and environmental uses. We've got partnerships where we help spray service providers learn best practices. We've got partnerships in Africa, especially because desert locust has recently become a big, big deal. So we're really focused on controlling and managing that. And last but not least, I want to go into just what subsistence farmers deal with and the decisions they have to make. And I understand that this is an Indian farmer, but it's really important for us as professionals to understand what kinds of things that they have to contend with every day. So this is Akash with his 3 kids and his pregnant wife. They live together in a small one-room house. This is not actually his house. They took a picture of a different house. Akash rents a piece of land, very small piece of land on which he grows spinach. This little bug can destroy the entire spinach field within 2 weeks. He uses this is not a Bayer product, but he uses this particular product to fight this bug, and he can mix the product at the same spot where his wife usually makes dinner. This can be a real problem. You've got kids exposed and things like that. His son can help him mix the product, and he applies the products without sturdy shoes, no certified clothing or other protection. He intends to harvest some of the spinach a couple of days later to sell it at the local food market. This is the reality for so many agricultural workers. And if they lose their entire crop, they're talking about really risk of food security. What is his wife and kids going to eat? What is he going to sell at the market? This is what we want to be able to try to prevent and make people have health for all and hunger for none. So they can have the most abundant food supply and the best training to be able to prevent this kind of farming that we've had access to in the West. In 1900, 45% of the American population farmed. And we lived to the ripe old age of 45. And because of agronomic practices and improvement of agronomic practices, we were able to lift subsistence farmers up from poverty and make them productive enough to be able to send their kids to school and get into professions and things like that. agriculture is the foundation of civilization. The reason why you and I can be doctors is because we have people feeding us. And in the United States, by the year 2000, we have less than 2% of our population farming and feeding the rest of us. I believe Africa deserves access to the same tools that has made the West absolutely successful in our farming. So what are we doing to fix this? We've trained more than 5 million farmers per year. We're active in 3 regions, Asia Pacific, Middle East, and Latin America. The topics we're talking about are safe application, safe transport, safe storage, first aid, safe disposal, how to get protective equipment, and spill management. We've trained lots and lots and lots of farmers, and we plan to continue to do the same. These are important contact details for Kenya. And Asante, very much for having me today. I'm happy to answer questions.
Thank you very much, Dr. Lockwood, for quite an insightful and educative session. As you catch some breath, if you have questions, please type them on the Q&A section. We'll be able to answer some, if not all of the questions. Some of them have already been answered. For those that have not been answered, we'll see what we can do. Feel free to ask questions on the Q&A section.
I'm going to stop sharing my screen. Has everybody seen these numbers okay?
Yes, yes. All right. So we have a question for Dr. Lockwood about a comment. Someone is looking for a comment about the DDT ban in the West, but still on use locally.
Yeah, so DDT actually turns out to be really important for malaria control. And we can talk a little bit more about DDT. DDT revolutionized the management of insect-borne illness. It was discovered by Dr. Paul Mueller, who was a Swiss chemist in the 1930s. And at the dawn of World War II, there was a huge need for a very low toxicity insecticide, because in the military, one of the leading causes of death is actually insect-borne illness rather than war wounds. And pyrethroids were offline because most of the chrysanthemums were grown in Japan. And so it was very hard to get a good insecticide that had low toxicity for mammals out. And so when Paul Mueller discovered this, it really, really changed public health. DDT is responsible for the eradication of malaria in the United States and Europe. In 1953, Sri Lanka had 18 cases of malaria. And the National Academy of Sciences credited DDT with having averted 500 million insect-borne illnesses and 1 billion insect-borne deaths and 1 billion insect-borne illnesses in 1953. So DDT's got low toxicity for people, but big toxicity for insects. And the reason why it was banned was because it was like a broad spectrum antibiotic, if you think about it, and it got widely used. Insects built up some resistance to it, and it tended to bioaccumulate up the food chain. It would hit off-target insects. And then, birds would eat them and things like that. So the concern was that it was having off-target effects and it was persistent. It's still very critical for malaria campaigns. And so, especially where there's a large burden of falciparum malaria. So you'll find in some houses, DDT is kind of interesting because it not only has insecticidal properties, but it also has repellent properties. So mosquitoes won't want to come into a house that's got some DDT. So there are some formulations where they paint DDT on the walls in where there's a large burden of falciparum. And that, once again, is not going to be a huge, that exposure is not going to be a huge problem for people. And the risk of malaria is much higher than the risk of the exposures of DDT on the wall. So that's why it's still used locally. And it's interesting. We'll see why DDT. There were 5 endemic cases of malaria in the United States, and with global warming this past year, with global warming, we may start seeing Anopheles mosquitoes, travel further and further north. So this could become an issue in the United States. The next question I see is, do we still use activated charcoal for oral ingestion? I, as a toxicologist, only use activated charcoal in certain ingestions that are pharmaceutical overdoses, and it's only within the first hour post-ingestion. And that is if the pharmaceutical actually binds to activated charcoal. So in pesticide exposures, I tend not to use activated charcoal, and I never use activated charcoal in anybody who's obtunded, because there are cases when people have put down an NG tube and poured activated charcoal down the NG tube, and it's wound up causing getting into the lung. And so I tend not to use activated charcoal for, I wouldn't use it for pesticide exposure. Okay, kindly share the link and website to watch last week's session. Okay, we'll do that. Sometime back, mercury was found in sugar. If their food and products safety regulatory bodies, the Kenya Bureau of Standards. I don't know about that case about mercury. Maybe somebody from Kenya can tell you, but I do know that people pay very close attention to residues and things like that in the food supply. So I'm going to defer to somebody from the Kenya Bureau of Standards about mercury in the food supply. Could you consider having at least a starting dose of activated charcoal as a first aid measure accompanying most packages of toxic pesticides? I would say that activated charcoal, especially in liquid formulations, is probably not going to do a lot of binding, especially if you've got a corrosive injury to the esophagus. I think I probably would not have activated charcoal there. Now, if you had somebody, well, we can talk about, if you had somebody who had like a paraquat ingestion, that might be useful, or Fuller's Earth might be useful. So I'd have to think along those lines, but routinely, activated charcoal is probably not going to confer much benefit. Let's see. Do we have any home kits for testing pesticide residue in tomatoes? I am not aware of any home kits for testing pesticide residues in tomatoes. One of the nice things about pesticide residues is you can just wash them off. And remember, most plants make their own pesticides to defend themselves. So the concentration of natural pesticides that plants make is going to be much higher than any residue that you're going to have on an external like tomato plant or something like that. Remember, plants can't run away from you, so they make their natural own pesticides. And we talked about cassava last week. Cassava has a chemical that can get converted to hydrogen cyanide if it's improperly prepared. And there have been cases of cyanide poisoning outbreaks in improperly prepared cassava. So Mother Nature is full of toxic chemicals that people ingest all the time. So I wouldn't worry about testing pesticide residues at home. Who provides drone spraying services in Kenya for small-scale farmers, and is it economical as hand spraying? I think they're doing testing right now of drone spraying and in order to get regulatory approval for those kinds of things. So it could be very economical as opposed to hand spraying, but at the moment, I'm not sure what the status is of the regulatory approvals in Kenya. Maybe somebody else can answer that question. Let's see. If I induce diarrhea, is it going to do any good to the poisoning patient? No, it's really not going to do any good to the poisoning patient. In this cases, sometimes it's good to do a gastric decontamination which is different than gastric lavage, right? Whole bowel irrigation when you try to get flush stuff out, but that's usually for a different kinds of pharmaceutical overdoses. In this case, what you're going to be doing if you induce diarrhea with a cathartic is you may cause a lot of dehydration with the patient, and you're just going to make a big mess for yourself. So I would avoid this. Often, like with organophosphate ingestions, they'll be having lots of diarrhea on their own. So I would stay away from inducing that. So let's see. I think I've covered. Have I covered all of the questions?
Yes, Doc. There's a comment though about receiving calls regarding skin irritation with use of mosquito nets. What's your...
I didn't. Can you say that again? I didn't quite hear you.
There's a comment about having received calls regarding skin irritation with use of mosquito nets.
Oh, skin irritation with the use of mosquito nets?
Yes.
So with pyrethroids, once again, you can get, most mosquito nets are embedded with pyrethroids, and those, if you get, especially if you get like warm water and things like that, you can wind up getting this cold burn. It's not a burn, it's a paresthesia. And the paresthesia will resolve on its own. It's not a sign of toxicity. It's just that when you get exposed to it on the skin, it depolarizes nerve endings, and that can cause more paresthesias than anything else.
Thank you for that. Another question is where and how frequently does Bayer conduct farmer training in Kenya?
I would have to have, we do conduct farmer training in Kenya. I would have to have either Jayesh or Vinay actually answer that question, or maybe Susan can answer that question, because I am not involved with the actual farmer training. I do the global medical component. And then Roundup and cancer. Roundup is actually not a carcinogen. We have looked at, not just us, but worldwide regulatory agencies have looked at this in great detail. And just as recently as last year, the EU renewed glyphosate's license across Europe, because glyphosate is the most important chemistry in agriculture. It is as important for agriculture as antibiotics are for medicine. And we can do a much more detailed discussion of this if you'd like. I'm happy to provide a whole talk and data on this if you're interested at some point. But long and short is regulatory agencies around the world, including the assessment group on glyphosate, which was 4 countries last year, looked at all of the studies, all of the 50 years of use, and found no association, and published an 11,000-page document and reasserted that this does not cause cancer. This is really so critical for people to understand. There are 6 other companies make glyphosate as well, and they've all done these huge regulatory studies and independent studies that demonstrate no association. Most recently, the National Cancer Institute of the United States of America conducted the Ag Health Study, which was published in 2018. That study has looked at farmers, licensed applicators, 57,000 since 1993, and followed them all the way up until now, and have shown again and again that there's no association between glyphosate and any kind of cancer. So this is just a feature of the American Trial Lawyers Association, but I'm happy to do a talk on glyphosate specifically if anybody's got questions about that.
All right. Thank you so much, Dr. Lockwood. I think the rest of the questions have been answered. Okay, there's one more, I think. Is Vacon a carcinogen?
That I'd have to look at that. I'm not sure what I'd have to look at Vercon. That may be a trade name that I am not aware of in the United States. So I will get back to you on that. I doubt it though.
Thank you. I think one of the last questions we'll be tackling, how selective is drone application of pesticide? Is the precision with regard to sprays or the ground of application?
You can have very selective application with very with very selective nozzles. So it can really decrease the amount of drift. Instead of having like a big plane go over and just sort of pour stuff on, you can pick out selective plants that you can go on. So it can be very precise.
All right. I think with that, we come to an end on that session. The rest of the things will be sorted about the slides and CPD issues. They will still be sorted. Thank you for participating, attending, and also thank you for the questions. And thank you very much, Dr. Lockwood, for the insightful presentation. I think we meet next week on Tuesday.
Yes, and I'm looking forward to it. I really appreciate the opportunity to talk to you all about this. And please feel free to reach out with any questions. I'm happy to answer them.
All right, thank you. And then there was a request to have the contacts, the Kenyan contacts displayed. Yep. Yeah.
Oh, yep. Let me share that again.
Thank you.
Thank you very much for your time. I will see you next week. Feel free to reach out with questions.
All right. Have a great week.
You too.
You too. Thank you.